like to introduce Dr. Tommy Gerschman, who is with Doctors of BC. Dr. Gerschman is a community-based pediatric rheumatologist with a focus in pediatric sports medicine, practicing in Burnaby and North Vancouver. He's been involved in digital health for many years, working alongside provincial organizations such as Doctors of BC and nationally with the Canadian Rheumatology Association, both of which he has served on as a board member. In addition to his leadership in stewarding digital health within BC, Dr. Gerschman has played pivotal roles in enabling virtual health within the province and supporting physicians in adopting digital health tools, including AI scribes and other systems, including Care Connect, which we know well. More recently, Dr. Gerschman has been providing specialist perspectives as part of the collaboration between Doctors of BC and PHSA on the Provincial Digital Orders and Referrals DRO initiative. This has included supporting the implementation of the provincial e-referral system based on the OceanMD platform. And Dr. Gerschman will be talking to us briefly to give us an update on where this e-referrals project is in BC. So welcome, Dr. Gerschman, and I'll let you take it away with what you have to share with us today.
Great. Thank you very much. First of all, I do apologize. I'm getting over a bit of a cold here, so might not be quite at my 100%. Was great to catch the end of Kathleen's speech there. I had the pleasure of serving together with her on the board for a little bit, so it's always good to see people who are reaching high and achieving incredible things for our profession. So thank you, Kathleen. And I think, some of what Kathleen was talking about resonates a lot. And I think with all of us about the importance of having overall structure and having the federal government act and set, direction and North Star interoperability. But at the end of the day, the details matter. The fine print matters. It can't just be top down. We need to also know from the grassroots, from the front lines, what's going on. And that's kind of how I've framed my discussion today, which is the value and effectiveness that we gain through engagement and using the digital referrals and orders journey as a bit of an example of that. And really sharing things a little bit more from a specialist perspective, my own kind of experiences and thoughts on this. But I think that with digital things especially, sometimes things seem to be decided in some other room by people who aren't actually necessarily seeing patients, and there's all sorts of examples. One that quickly comes to mind that was last year sometime was when the government decided to add to the health info gate or the health gateway for patients access to their documents and reports and all sorts of different notes that would clinical notes from the hospitals, and so that the patients could log in and basically see whatever letters and communication from doctors. That when that was sort of suddenly announced, it brought a bit of a shiver to me, because I just remembered this was maybe before AI came and has its own problems, but with speech recognition, things would always go a little bit awry. So I remember one time I saw a patient and I had said his parents have gone to Korea, and out came his parents have gonorrhea. And that, of course, I was able to catch and correct, but I thought, wow, if you're not really on your toes and all of a sudden patients have access to this kind of unfiltered, you should be reading all your documents and things. But those types of things and what impact does that have on physicians? That means I have to slow down when I do my documentation and dictations. And yes, that's better quality, but it has an impact. And if we don't have the right engagement with physicians and frontline workers on that, then we can run into all sorts of problems. And so I think that by having true engagement with the end users, we can really drive up value and also the feeling of being valued, and also the effectiveness of whatever it is we're trying to achieve. And so I want to talk a little bit about this DRO program, Digital Referrals and Orders program. And in the intro, I think, it was sort of this relationship with PHSA kind of owned the government side of that. Now PHSA has sort of shifted and molded, and they have this new shared services division or authority, or I don't even know what it's called, but so it has shifted a little bit from PHSA. But this DRO journey, I want to talk about it from a big physician's picture lens, and a lot of that work was via Doctors of BC. How that engagement has affected peers and colleagues, and really that communication between referring doctor and consulting doctor in the e-referral system, and then also engagement through patients. Um, so, I gave that kind of example of stuff that happens that sort of almost feels like an edict to us, and then we have to scramble to figure out how to change things. And that's, of course, nothing new. We take a moment and go back, way back down to 2018. The government at that time had received an external report on Island Health's Cerner misadventure, and I don't know how many people remember that or so on, but it was, as usual, over budget. But it was so bad that they were flying in doctors from Alberta to do order entries because the physicians, primarily in Nanaimo, were so frustrated with the process, not trusting the process, not trusting the system, that they thought that it wasn't medically appropriate to do it. And so they hired external doctors to kind of fill the gap. So definitely the opposite of a good example of engagement, where people really didn't feel valued, and certainly wasn't a very effective nor cost-effective way of doing things. Now, at the time that report came out, they were embarking on an even bigger initiative in Vancouver and the Lower Mainland, which was the CST, which was again the hospital conversion of technology, which was also over budget. And between these two, at the time, it was about $1 billion over budget between the two initiatives. So not small change either. So I don't know exactly if that kind of made people think maybe there's a better way. I hope it is what helped them think about a better way of doing things. But around that time, they also started talking about developing a digital health strategy for the province that would hopefully take learnings from these initiatives and think about how we could take these provincial level modernizations that needed to happen, but do it in a better way. And so if we fast forward a few years, there was definitely the pandemic, leadership changes, and so on. So lots of things kind of between that report and when we got to 2021, where we can pick up this story, where they had devolved a lot of this digital health strategy work to PHSA at the time. And at Doctors at BC also positioned themselves to be ready to be partners and had approved a policy. The Doctors of BC board had approved a policy calling for engagement and physician participation in both digital and IT initiatives relating to health, saying doctors must be involved in those discussions. So when the government decided it wanted to implement a closed loop provincial e-referral system, Doctors of BC was brought to the table to help inform this, what would be a multi-year physician informed initiative. Now, what is a closed loop e-referral system? Basically, it's meant to replace the fax and be a more consistent and secure system to facilitate referrals. And I think most of us around the table know why this is so important. I did want to share a personal story, which I'm sure you or your patients can relate to. Just a couple months ago, or a few months ago, I got a text message from my dad. And he said, "Oh boy, we've been calling back and forth between the X-ray clinic and BC Cancer. X-ray clinic said that they already sent a requisition to BC Cancer Agency. BC Cancer Agency says they didn't receive it. Mom called back to a rude X-ray clinic MOA who said it had been sent. So then mom asked from which fax number. Called back to BC Cancer Agency who said it was the wrong number. Called back to the X-ray clinic and asked again. And finally, the MOA checked with the person who's sending the faxes and found out, oops, wrong fax number. Would be sent out again today with the right number. What a waste of 1.5 hours. Faxes are so old-fashioned." So that was from my dad a few months ago. And we know that this type of experience happens over and over again every week. And back in 2022, this exact issue about orders and referrals was what 8 different physician workshops had concluded was a priority that needed to be sort of fixed and addressed. And so that's one of the reasons this idea of a closed loop e-referral system kind of rose to the top. And with Doctors of BC, the government went through a long process of defining what they wanted, what needed to be done, having a RFP or request for proposals, awarding that proposal, which eventually went to this Ontario-based company called Ocean MD that had also done work in Ontario and Nova Scotia, and then started deployment of this program and implementation in collaboration with Doctors of BC and various physician groups, which we'll chat about more in a second. Certainly had ongoing conversations with Pathways as well, which serves a continued important role in working with physicians across BC. So that work, continued, and this slide is a little bit old. It's from fall of 2025, but the work was a little bit slow to get going, and we can talk about why that kind of was. But by the end, they had developed 33 digital referral templates that had replaced over 100 separate forms. They'd onboarded 126 sites, which included over 800 providers. Over 2,800 referrals had sort of been processed back and forth. They were bringing community imaging clinics on board as well. Already 75% of the BC EMR market share was integrated into Ocean, and so could be an integrated EMR. It's even higher now because they've brought online Plexia as well. Multiple radiology clinics were live integrated, and work was underway to sort of move things along. But what happened was that in February of 2025, there was a pause that happened for a whole bunch of initiatives that PHSA was involved with the big sort of government spending review, and a lot of this work was paused. The sites that were already on board and working could still work in the background, and so they weren't stopped. But the new onboarding and further development of different things was all paused while there was a big review happening of a number of different PHSA initiatives, including the DRO initiative. Now, through this, as I mentioned, the importance of engagement. There was a lot of different engagement at the time, both with family physician groups, specialist groups. We had 22 different sections involved, the FPSC and SSC, Consultant Specialists of BC, BC Family Doctors, and so on. We had different clinical advisory groups that were open to anybody to join that was talking about different topics and how this implementation would roll out. We also had specialty working groups, which was meant to help develop forms specific for a specialty. So, for example, orthopedics would come together with some representatives from family practice, MOAs from the specialists, as well as the family practice groups. And they would talk about what would be the most effective way to structure a referral over to orthopedics, and try to take the dozen different forms that different orthopedic groups do, sort of blend it down into one, and that be the sort of the one preferred orthopedic referral form, for example. And so what did this bring us, this kind of broad level of engagement? Well, I think, again, from a value point of view, I think by engaging multiple levels of physicians, both formal groups like FBSE and SSC, but also having an open call out for anybody who was interested through these clinical advisory groups, the CAGs, was a way to really make people feel valued. If they wanted to provide input, they could. We spent a lot of time tweaking and updating the different user agreements, both that Ocean wanted users to sign and PHSA wanted users to sign. We made sure Doctors of BC had their teams go through so that it would make sure that the burden wasn't unfairly put on physicians. Like if the whole referral system went down, that there would be a shared responsibility for different things, as well as the cost. Um, Before all of this, if people wanted to subscribe to some of the other engagement tools that Ocean offered, it would be about $25-$30 a month per user. And that would all kind of come as part of it. So it was sort of an added benefit for people who joined part of this e-referral process. In terms of effectiveness, I think this engagement really helped take that kind of multi-stakeholder provincial level. So instead of having different silos, different sort of semi-solutions for different areas, it was really looking at it from a provincial level. It was also learning from what had been done in Ontario, which has used this Ocean e-referral platform for quite a long time and have renewed their involvement, as well as Nova Scotia, who've also engaged with this sort of provincial level e-referral system. There was also a tech support process put together so that there would be local tech support from PHSA for sort of level 1, level 2 type supports. And then for higher level of supports, there would be a process to involve Ocean, for example. Now, as of the last couple of weeks, or the last week or so, there has been a formal restart of the Digital Referrals and Orders program. It's now under this new kind of health authority, the BC Shared Health Services. It is sort of looking at where are we at and trying to sort of now after things were paused, a lot of people left for different jobs and got involved with other things. So it's sort of putting things back on track, restarting things. It's going to be looking at people who expressed interest, and there was a long wait list of people who were interested. Hundreds of clinics who'd expressed interest, and sort of taking a step-by-step approach for onboarding people again. Part of that onboarding is making sure that people feel that there is a smooth workflow that's put together. And again, by engaging closely and not just sort of dropping it off and letting people go, there would be anywhere from sort of, I think, 4 to 6 hours of work that was paid sessionally as well, with this to help ensure that people felt that it was well integrated into their workflows. I think this restart, the plan as well, is to use a region-based approach, so that we can try to develop critical masses, because we know that you need both. You need enough specialists who are engaged, as well as sending doctors who are engaged to make it meaningful. Now, Ocean as a system actually has a number of different functions. And so the e-referrals part is what we've just talked about. It will also be working on e-orders, which was something that was started before the pause. And that was really to help send labs. So this was Life Labs. They developed basically a form that you would be able to do an e-submission for Life Lab rec, so that you didn't have to print something out, you didn't have to email or fax it. It would just automatically send directly from the EMR. And there were other e-submissions like special authority requisitions and such that could also work. And e-consults is something that's always been sort of on the back burner, which not sort of currently in scope. And then the Ocean Health Map, I'll show you a quick little view of that, but that's basically just how they organize their sort of search engine. I tend to ignore the actual map part of it, but I'll show you that in a moment. So, so again, this closed loop referral provincial e-referral system, I think, again, if we break that down into closed loop, that's all about reducing those faxes and trying to address that story that I shared. I think provincial level is trying to do something so that we reduce silos and fragmentation, and really by taking a provincial approach and recognizing what are the current EMRs that are in use, and how do we capture most of those to make sure that we have an integrated system so that schedules sync and so on, is also really important and been a priority for the and then e-referral system, of course, is something that passes information on, including demographics and attachments electronically, so to help improve both the quality and consistency of this referral communication, and hopefully also help make those college guidelines about communication more consistent. So these were some of this we already looked at. I'll skip over that. So I took a few screenshots to just for people who haven't seen it to kind of look. So this is the ocean health map, which does allow you to sort of see how far away and where exactly somebody's located. But it has various search functionality. If you search me up, so pediatric rheumatologist, this will come up, and I do a mix of sports medicine and rheumatology. And if you click on send a referral, then this form comes up. Now, I didn't have it logged in with a particular patient, but normally it would have all of this auto-populated in terms of the patient's names and demographics and so on. And the form, and I think the important thing to look at here is I used what was called the standard referral form, which was the generic form that I think 80-90% of specialists chose to use. And you can click through here. Do they have preferred pronouns? These are optional things. Really, the important thing is what's the reason for referral? That's kind of a mandatory field. Everything else is optional. But if there are other things like alternate contact required for communication, if you press yes, a little thing will pop up that you can enter that information. Here is an example of a different one, a GI form. So this is what the GI doctors made. So again, you don't have to be searching for the latest form. Whenever you click on somebody's referral, whatever they've chosen as the form that they prefer, that will be what comes up. And it can have some smart logic to it. So for example, if you wanted to refer them to GI for a lower bleed, it'll give you these recommendations and considerations and other things that I know they in paper forms and other things that they've tried to have as well in the past for some referring forms, but this is all in one. This is just a screenshot of my EMR. So I use Accuro just to show how it looks on the specialist's receiving side. So you can see here, I got an ocean incoming referral, and this is what it kind of looked like. So it came out, the referral form summary, it has this reason for referral. That's all I kind of really wanted. It had all of the patients, here's the patient's demographics were all automatically added. And so it, looks a little bit neater than a fax. Certainly, it's certainly not handwritten. Don't get too many except from Emerge that are handwritten anymore, but nicely printed out. The other thing is you can see these e-referral attachments came along. And so just like any sort of labs or what have you would come across digitally as well, which is great. If you look, I just scroll down there, I have all these different quick action buttons. So there are ways to sort of pop straight into different functions of Ocean. And if you click into a dashboard of Ocean, you can see this is what if you go through the e-referrals or dashboard in Ocean, this is what it looks like. So this is a different patient, but you have, again, the reason for referral. But here you can have communication. I can add notes back to the referring doctor. I can put the time and anticipated wait time for the patient and communicate directly to the patient and CC the referring doctor at the same time. But Ocean does a lot more. It also does engagement with patients as well. And so I just wanted to show some quick screenshots of that, how I've used that. First of all, there's appointment reminders. And so this way I used it in a bit of a novel way was that when I had patients that would have Zoom visits, I would make sure that they got the Zoom link and it would pull the Zoom link straight from my EMR. I would paste it into the EMR and it would sort of put it in. Can't remember exactly where in here, but it would insert it automatically into here. You could decide, how many days before the appointment do you want it sent? Do you want it to involve appointment confirmation? The different types of patients. So VH for me is a virtual health appointment. So you could set what types of appointments and different rules that it would be sent out for. And it would automatically include the appointment date, the appointment time, and so on. So that's just a simple appointment reminder. You can also choose to send text messages. I just stick to the emails, but you could do text as well. You can also send forms. So as a rheumatologist, I sometimes will send out a BASDI to certain patients who have juvenile arthritis, and I'll ask them to fill those forms out. It sends out 3 days before their appointment, so I don't even have to think about it, and they'll just fill it out and complete it. So I have all the information there when needed. This is an example of a form that's for a concussion patient. So I get them to fill out concussion questionnaire before. It asks them to score themselves, how much of a headache do they have, and so on. These are all standardized symptom questions for concussions. And on the side here, you'll see this is what gets entered into the EMR. So it gives you just the numerical, but it also totals it up. So 8 out of 22 and severity score is 22 out of 132, for example. And that's useful to me to know what the total is. And it actually can capture it also as lab values. This is just an example, back to the BASDI example, of one of my challenging patients with juvenile arthritis who just tracking I can see numerically how their different disease activity and pain scores are. And graphically, I can also see it. And you can see it's kind of all over the place. The poor guy has lots of pain, coming, going, coming, going. A somewhat better example was this patient where you can see the pain sort of values going way down. And interestingly, if you look at when I started methotrexate, it's, 6 to 8 weeks later, that's when we see the pain scores drop. So it's kind of nice to be able to automatically track that. And for me not to have to think about every time, did I send the form? Did I get them to complete the form? It's just sort of automated based on their appointment type. And then the last one I wanted to show you was I have all my new patients fill out a new patient intake form. So that's just up here. And it asks them a bunch of questions. It pre-populates some of the things like their name and date of birth, but then they fill in, make sure their address and phone number and everything's okay. I ask them to put their family doctor if they have one, and also what preferred pharmacy. And then you can see on the right-hand side is how it kind of builds out as you work your way through this. And I asked them about different sports participation, and it puts it into a nice little paragraph format. And if I ask them even more about their family history, now you can see it gives a nice sort of paragraph format. I programmed it to based on their answers. And it actually works really well and helps me sort of focus on the things that are perhaps more relevant and problematic. And if I do forget to ask something, I know I always have a backup to go back to see if they answered it. Now with AI, it maybe doesn't matter as much that it's nicely worded like this. Before I could just copy paste this and didn't have to do too much editing, but now with AI, it's probably even less important that it looks perfect. So it has all these different functions that I think from a patient perspective does give this sort of secure platform that allows for that more integrated sort of transferring directly back and forth to the EMR, which helps also be more effective in that it pre-populates things. It helps with documentation and helps reduce some of the time spent during the visit as well. And so just coming to the end here, this is this DRO program is restarted. And I think that, again, the value of what I see of the DR program is the level of engagement that we've been trying to strive for by taking multiple levels and opportunities for engagement, both at the sort of more system group level, FPSC, SSC, and shared care, and so on, but also opening up for individual feedback and comments. And looking at really how do we add value for physicians and patients when it comes to integrating these tools, because change is always hard. So we want to make sure that it's value add and not just a make work project. But in saying that, the work now sort of continues and we'll keep going, and happy to take a few questions.
Well, thank you, Dr. Gershman. I think our clinic in New Westminster was one that was engaged maybe a year or longer previously and attempted to integrate Oscar MD, Ocean MD rather. Sorry for the misspeaking. And then it got put on hold. I'm still keenly interested in knowing how well it works in BC. I have heard from transplanted doctors from Ontario who basically vouch for its usefulness from whence they came and wonder why it's not here. So I guess Ontario's losses are gained because now they're BC doctors, and that's what has me scratching my head. Where is it being used and how meaningful is its functionality?
Yeah, I think that's a great point, and I think that Ontario, you know, took a slightly different approach. I think was less coordinated, a little bit more sort of do it yourself, like and so sort of uptake has been very slow, and I mean broad uptake I think has been slow and gradual there, although picked up steam now. Nova Scotia was kind of the flip side of that, which was very mandated. It was like everybody has to start now. And BC said, we want to try to find something in between. We don't want to force anybody. I think, being voluntary and giving autonomy to people, I think is still very important for physicians and doctors of BC. And but at the same time, having a more coordinated approach, assisted approach, let's engage with different groups and different sections to make sure that we get broad buy-in. That took a lot of time to get going. And we were sort of picking up, I think, a lot of steam and momentum, quite a bit at the time that everything was paused. And that pause was a broader pause and review. It was sort of caught up in that. And so I know a lot of people sort of were like hearing a lot about it, and then suddenly it was radio silence, and which was very confusing for a lot of people. I do think that you're right in that for it, like there's multiple aspects of it. For the e-referral part, um, obviously, until there's a critical mass where everybody you refer to is on it, you're going to have to use more than one pathway, right? But hopefully, the idea is that it, you know, if it is, by having that single form, that smart forms, that more one click, we don't have to worry about did the fax go through, didn't it? I mean, I get so many times that I have faxes for referrals where it says, June 1st, received fax June 1st, but the date on the referral is like March 30th. And it's like, what happened, right? Did it not get sent? Did it not go through the fax and so on? So I think it will hopefully start gaining some momentum again. I think some of the other engagement tools, it depends. If you already have a solution that works really well for you, is it really worth for you stopping using whatever patient messaging system you might have to use something new? Maybe not, but if you're frustrated and want to try something new, then maybe it's a two for one type opportunity.
I have a question for Dr. Gershman. So OceanMD, of course, is owned by an EMR company, and that EMR company was and maybe still is under investigation by the Competition Bureau of Canada. And so I'm wondering if he has any concerns about that.
I, I, I mean, bottom line is that's certainly over my head. I mean, my role has been as an end user of this, and also as making sure that physicians are being engaged and discussed, and sort of their end user experiences are being reflected in decisions and so on. I think we all, of course, want to make sure that the programs and systems we're using are acting as ethically as possible, and so on and so forth. So I think those are good and important questions. From what I know and have experienced, I mean, although OceanMD is owned by Well Health, I think they do operate as sort of their own little subsidiary. I don't know. I don't know how they're corporately structured. I just know that it is kind of this, it still has its own corporate structure. But I don't know. I don't know how their corporate governance works.
Sure. My follow-up question to that, of course, is that the parent company has also bought a company in New Zealand which sells health data to third parties, including private third parties. Now, supposedly this is stripped of identifying data, but would you find that concerning as well?
Yeah, I mean, as I said, one of the things that probably slowed us down 6 months in terms of the initial launch and integration was getting the appropriate user agreement language down. These types of things, secondary use of data, and all of those things were so important to physicians. Even things like, I mean, from a specialist point of view, even the use of waitlist data, right, was something that a lot of specialists felt was very personal. And they were like, I don't know how much I want the government to know what my personal waitlist is on a day-to-day basis. And if they are, it should be like the empanelment process and attachment system. Like there should be a give and take type process for that. So there was a lot of time being spent on the user agreements that were specific for BC physicians coming on, and in particular, some of the discussions around secondary use of data. So I think that was not specifically related to whatever the purchase was in New Zealand, but conceptually, those types of issues were certainly front and foremost in terms of what people were thinking about.
It's interesting that you use the phrase "you have to choose your own pathways." I am still keenly interested in knowing which clinics, perhaps only in Vancouver, are using OceanMD preferentially over whatever they used to do in the past. A change for the sake of change must be meaningful and enhance what I do and not be a horrible step backwards, as I hinted at earlier. Are there such clinics?
Um, I think there are various clinics that have made the switch, but I think again, part of the value is reaching a critical mass, right? So I think you had some early adopters, and then we were entering that sort of early, what's it called, the early mass phase, right? Like you have the early adopters and then the next big chunk, right? The first third kind of thing. We're lining up, and I think there was a wait list, like I said, of multiple hundred clinics, and then things were paused and stalled out. So I agree with you that sort of reaching that critical mass over the next 6 to 12 months is probably going to be really, really important. And if not possible to do so, it sort of does put things into question about what's the value of this if there's only 10 clinics that are using it, which is, I think, some of the experience that happened in Ontario, is that because there wasn't much effort to get people on board and show the value of it. I think it was very patchy in terms of who were using it. But obviously the people who came here who had used it and liked it, right?
Understood. You're in a catch-22 awkward situation. And I don't have any answers or helpful hints there. But
I think I should say one of the things from a specialist point of view was, is it integrated into my EMR? And I think as opposed to like Ontario, we have a lot of Plexia users here, a lot of specialists who use Plexia. And Plexia was not integrated. They do now have integration like coming online with. So I think that will also help significantly. Clinics that had used Accuro or Med Access, which a lot of specialists also use, certainly were more eager to come on board. And we had other clinics, of course, with Oscar as well.
I mean, apropos to Dr. Ross's presentation, this has huge implications to all and every EMR user, not just Oscar, because it will fundamentally change how we may be legislated to use our system. And anything that enhances our safety, security, efficiency, and job satisfaction is positive. Right now, I can't see myself engaging if it's of limited use, and that is the conundrum, the dilemma you face promoting this. A different approach needs to be taken, a different pathway, if you will. But you know, Dr. Ross and I went through this journey to some degree for a different situation, and we came through very well in that regard. And I'm not sure how you're engaging end users to succeed in this regard. I'm hoping it happens if that's the push, but right now it just has me hesitant.
Yeah. Yeah, I think you're absolutely right. And again, what I have certainly stressed and my colleagues and doctors at BC has been this needs to be voluntary. I mean, the government very well could say everybody has to be on right? I mean, they could force the college to say it or whatever, right? And that's what they did in Nova Scotia. That's what they did in Nova Scotia. And we have said, absolutely, if you want to work with us as partners, this needs to be voluntary. And for it to be voluntary, realistically, it needs to be value add for physicians. And the way you get value add is you talk with people, you engage with people, you listen to where their frustrations and roadblocks are. And that's one of the reasons it took a long time to get going, to get those systems in place. We were, I think, making good progress until that pause. It has just been restarted as of, I don't know when the official, but like essentially last week. I think Kathleen might know. So, let's see what the next few months bring. I think they need to hire new people and get dust off some of the procedures and things like that. I think re-engaging with partners, Kathleen mentioned also no wrong door approach. I think that from the very beginning, certainly myself and my colleague Barinder Narang had said whatever we do needs to also kind of be holding hands with pathways at the same time, because that's something that's obviously a directory and a system and a whole system that's used by the vast majority of family physicians and others now across BC. And so if you don't, one of the things I always said was, if you don't want to use the health map because it's kind of clunky, you should be able to enter into this system other ways. And I think that's kind of what a bit of the no wrong door approach is about. And it technologically, that shouldn't be that hard to do. Yeah.
I might add to that, Tommy, because I think it's important that that the messaging goes out, and it's just started. And I posted the announcement actually in the chat that went out it's Monday or Tuesday. I'm sorry, I don't remember exactly the day either. But the integration of pathways into that planning and strategic level of the rollout of the DRO this time, I think is critical, because many of the lessons that John alluded to that we learned early on and continue to learn through pathways can certainly help to accelerate progress in this transmission form, and acknowledging the unique and defined role of the clinical navigation system that is pathways in 3 provinces across the country. So I think that there's lots to be done, and a lot of the questions that people have in their minds right now, I don't think US can answer. But ensuring that there's that sense of collaboration with the restart, and certainly I'm getting that right from Tiffany Ma at the ministries level, on down through Brent Kirschnell as the interim head of digital technology for the BC Shared Health Services. So I think there's a lot more that's unfolding, and really appreciate you sharing how we got to where we are, and we'll see where we evolve from here.
And I think the bottom line is, the more like we need to hold the government to engage with physicians, and there's so much diversity in terms of what physicians' needs are: family practice, large clinic, small clinic, rural, urban, specialist, procedure, like all these things. It's not going to be a one size fits all. How do we have a system that tries to understand and listen to different groups and get some of that feedback? I think that's at the end of the day, that's what we all have to collectively hold the government account to, so that we don't get into a top-down situation where the government makes a deal with some other, entity and says, we don't even want to hear from doctors anymore. We just want to hear from the corporates, whatever, right? I think that would
Yeah,
be
and I
nightmare
think
scenario.
I think the whole way this is unfolded, that's a lesson learned that we won't see repeated. But at the end of the day, understanding frontline workflow, both yours and others, I think is going to be critically important. But having knowledgeable people continue to engage with government, continue to ask for those policy decisions, continue to support innovation at the fringes, and make sure that we're building a system that's not forever beholden to one corporate entity. Those are all structural processes that we're seeing trying, governments both nationally and provincially are trying to fully embed as we go through these next few stages. So it's an exciting time to be in this field.
Okay. Are there any other quick final comments before we wrap up this afternoon?
Yeah, yes, can you hear me?
Very low, Dr.
Very,
Changji.
yeah, very low. Um, let me try to introduce you to what we call the TNI, which is the Taiwan National Health Insurance Card. What it does is that, you see, we use our cards purely just for demographic data. Now, in Taiwan, about 30 years ago, they adopted the Canadian healthcare system. And since then, they have improved the system, whereas we have not. And the big difference is the use of the intelligent card, where they store the latest 6 interactions with the healthcare system right into the card itself. So the advantage to that is that at all times, as long as they have the card, whichever doctor they go to, whether they're in the country or even if they have no uh, uh, internet connection, they can still get to the latest 6 interactions, and whether it's lab, physician, or radiology. Now, the advantage of that is that the basic information, which is the recent information for the patient, is available. And the card can also be used to transmit all these referrals forms and among the system, in the healthcare. Now, Taiwan has a population equal to that about all of Canada, instead of our various provinces. But since the card contains the basic information, what the doctors get out of it is that when you use the card in the office, it identifies who see what doctor, when, and for how long. So the only thing needed before they can pay you is for you to complete the clinical record. And as soon as you complete the clinical record in the central system, then the payment is authorized. You can be paid next day. You don't have to go through all this elaborate process of billing. So, and also, as I say, that in the event of any kind of natural disaster and there's no internet, the patients are still protected by their basic medical history. Now, the net result of all that is that you are free to use whatever system you use. And what is common is the information in the medical care card, which actually contains relevant clinical information. And they also incorporated the banking system so that these cards can be updated by the patient. Now, this way, the overall effect is that the administrative costs, the non-medical costs, as a total portion of the healthcare budget in Taiwan is 1%, whereas in Canada is more like 4 or 5%. So you can see it's a huge saving in the healthcare system. It encourages doctors to complete the records quickly. They can get paid easily without having to go through all this separate billing procedure. So that is one approach. I think that if we give it a little bit of study, will give us the freedom we want, the safety we want, and the patience. And the proof of that is if you go to Taiwan, you will find you can visit, the health cost is relatively low. I think it's something like $28 to visit a doctor in Taiwan. So that is a way out. But they build a system based on the Canadian system to begin with.
Okay, thank you, Dr. Changi. Any response to that, Dr. Yap or Kathleen?
Well,
Yeah, go ahead, John.
the concept of having a patient summary of some sort that's easily shareable is not new. 5 years ago at OscarCon, actually in Victoria, we presented something that would extract such information from Oscar and to basically enable transitions of care between acute and community. And 5 years later, we're still talking about how we can create a sort of a national patient summary that could be used in a similar fashion. And of course, BC has to do its own thing, has to create their own version of that. But that is indeed in discussion, and we're still kind of butting heads over what needs to be in there, including the last few visits, tests, etc. So it's the very thing that Dr. Chunkett was referring to.
Yeah.
Okay.
And one of the other advantages is this. The patient's wishes, whether they are organ donor, whether they want to be resuscitated or not, so-called patient directives is right in the card. So right away, if you know what the patient wants without having to be asked every time whether you want to be resuscitated, or whether you're an organ donor. So there are many other side benefits as well. And they can do it. They have done it in Taiwan. They are using it. So
yeah, my comment to that would be that Taiwan, and I've been at a presentation by the Taiwanese Health Authority on primary care reform, and their sharing of health data is very informative. But they're dealing with one unified healthcare system. In Canada, we have 14. And that is definitely a barrier. It's one that I hope that the legislation will take into account that will allow us to build towards that type of process, whether that's through Halo or some other process. It's not that governing bodies are not aware of that. It's this disconnect between federal and provincial jurisdiction that I mentioned in my talk earlier.
Thank you, Kathleen, and Dr. Yap, and for your input as well, Dr. Changi. We are out of time, plus a little bit. So I don't want to delay anybody on a beautiful Saturday afternoon and a beautiful weekend happening. So at this time, I would like to thank everybody for joining us today. It's been very informative, very enlightening and eye-opening to at a national level and at a provincial level of the changes that are coming, the changes that are happening, and will give us lots and lots of thoughtful food for moving forward in supporting Oscar users across BC and across Canada. So thank you everybody for joining us today. I see Dr. Gerschman has signed off. I don't see him. I will thank him separately. But if anybody would like to send more feedback or comments or anything like that, please contact us again at info@oscarbc.ca and forward your thoughts and comments to us. I will keep this Zoom open for board members, but thank you everybody else for joining us today, and you can please sign off and we'll close the day. Any closing comments, Dr. Yap, that you have really quickly?
Just thanks everyone for attending, listening, and supporting Oscar BC. I hope to see you in the future. I hope this movement grows because I feel there's a definite need for it to do so.
Okay. So thank you, and have a lovely weekend.